be a little bit detailed one. We find a little bit exhaustive also. Just try to. So the word vicarious, that is the definition, felt or experienced by watching or reading about somebody else doing something rather than doing it yourself. So that is the meaning of that word vicarious liability, the first working vicarious. So it is actually a term used when you watch a movie, you find the hero fighting and hitting so many people. So if you are too deeply involved in the movie, you will feel as though you are doing it. Even though you are not actually doing it, you feel or experience as though you are doing it when somebody else is doing that. So that is what is called the vicarious feeling. So it is in anesthesia, it covers the legal responsibility of a hospital or a supervising senior to the negligent acts of other medical staff involved in patient's anesthesia care. So it may be a junior doctor, as you said, or a nurse or a theatre technician, whoever it is, their mistakes are reflected on the person who has employed them or the person who supervises them. So there are some doctrines involved in this legal outcome. So there are 4 doctrines which are used in that. First one is respondent superior. This is a very important factor that you have to mention in the answer. This is expected in your theory answers. So respondeat superior, that means let the master answer. This is the principle which makes employer legally responsible for the wrongful acts of the employees or agents, and acts are performed within the scope of their employment. So this is how the legal words will always be in a little confusing man. So as long as they are in your permanent employment, it is the master or the person who has employed them who is held responsible for that. So this is the first doctrine, respondent superior. So in anesthesia, how does it apply? A hospital can be held liable for negligent act of an anesthesiologist who is a hospital employee, such as a resident or whose negligence action occurred while on the duty or on the clock. So while he is on duty, if any mistake happens, it is not only the anesthesiologist but also the hospital is held responsible. The second doctrine is called what is called borrowed servant doctrine, where if you employ somebody as a temporarily loaned person, for example, there is a visiting consultant. He is not on a regular payroll of the hospital, but he comes for a particular specialty because he is well trained in that, or he is considered as a very experienced person, and for complicated cases he comes, and he is coming only as a visiting person. Then the liability shifts to the temporary borrowing employer who controls the employee's action at the time of negligent act. So even if the employee is only temporarily coming, the liability will shift to the temporary employer. And in anesthesia, a surgeon could be held liable for hospital nurse's negligent action during an operation because the nurse was considered as a borrowed servant for the surgeon. And the application of this doctrine is complex and varies by jurisdiction. This is not routinely allowed or accepted in all the countries, but in some countries, this is the doctrine which is employed or used when there is a mistake. And the third doctrine is called the captain of the ship doctrine, where a specialized version of borrowed servant doctrine. So this is an offshoot from this one, where a visiting consultant or a locum comes, and the head surgeon who has full control over all the personnel in the operating room, and therefore liable for the negligence. So how does it apply to anesthesia? Many modern courts have abandoned or limited this doctrine, and anesthesiologists and surgeons are often considered co-captains. There is no question of, earlier it was dominated by the surgeons. But later on, and anesthesia for a very long time was called as the second fiddle specialty. or the behind the curtain specialty. But now both anesthesiologists and surgeons are considered as co-captains and are independently responsible for their own specialized areas. And any mistakes happening, that is individually considered. And when hospital has the right as an employer, it may be held liable for the negligence of a doctor. Where this right does not exist, the vicarious liability may be harder to establish. For example, when a visiting consultant comes and it is and many mistake happening, it is purely on the part of the visiting consultant unless there is a contract between the visiting consultant and the hospital, which is the documented legal evidence. In that case, hospital will also be considered to be liable for the mistake. And the fourth concept is what is called apparent agency or ostensible agency. So hospital can be held liable for an action of independent contractor if the patient reasonably believes that the contractor is a hospital employee. So whenever there is a visiting consultant or a borrowed person coming to the hospital, that fact should be known to the patient. That is a very, very important part. Otherwise, what will happen if the patient believes that the visiting consultant is also a routine paid employee of the hospital and it was not been revealed to him that he is only a visiting consultant, then the hospital will be liable for not revealing this information to the patient. So that is called the apparent agency doctrine. And where a patient receives anesthesia services without being informed that the anesthesiologist is only a visitor or a locum or a visiting consultant, then the patient has all the right to sue the hospital also. So when does vicarious liability apply? The hospital may be held responsible for negligence and errors committed by an employee. The employee should be a full-time employee and there is a right to control for the hospital. So he must be following all the rules and regulations of the hospital and he should be a full-time employee. Then the hospital will be liable. And what are all the conditions where mistakes happen or negligence can happen is a misdiagnosis, administering a wrong or untimely medication, or avoiding or not doing the medication when it is required, careless monitoring of the patient, surgical errors and mistakes and anesthesia error, and failure to follow up with the patient. So all these things are considered as negligent acts or mistakes that can be committed where vicarious liability will apply. And for the doctors, a doctor is responsible for supervising and overseeing team of other healthcare employees who are such as nurses and technicians. And if a member of the team commits negligence, does not provide a quality standard, then the doctor or the senior person who is controlling the team will be held liable. Now, what are the common defenses or protection the hospital may use for vicarious liability? It's common for an employer to argue that the vicarious liability does not apply to them because if the negligent person was an independent contractor, that is, he is not on the full-time payment role of the hospital. And the hospital also can argue that doctor or professional who made a mistake was not working within the defined hours of the expected time of employment. So any mistakes done outside the working hours also is considered not responsible. The hospital is not considered as responsible. And factors influencing responsibility, this is more or less the same thing is again repeated. Employment status, he should be a full-time employee. The scope of employment is he should be in their employment role and getting a salary every month regularly. And preoperative and postoperative negligence liability extends beyond the operating room also. So it is not only the intrapartum or intraoperative period where the negligence is considered. And delegation of duties. So the senior anesthesiologist can be held liable if the junior doctor or nurse senior delegated tasks within them who are under his control. If they do a mistake, then the senior anesthesiologist is responsible. And the criminal versus civil liability. Vicarious liability generally does not apply to criminal charges, and the individual is personally responsible for criminal act. However, the hospital and employee can still be civil liability for damages. So mostly it will not involve putting the doctors or the hospital owners behind the bars. That is the verdict or the judgment that will be given in criminal liability. That patient has to, or the negligent person has to serve in the jail uh, as a judgment. But most of the time, it will be only a damages or a compensation that will be claimed for the loss of life or a loss of part or morbidity that happen. So it will be a civil liability, which will be usually considered as a uh, claim from the patient's side of view. So the best practices for anesthesiologists to avoid this, what they have to do to mitigate this, these are the ensure a thorough pre-anesthetic evaluation, obtain proper and separate informed consent from the for anesthesia, that is proper consent for surgery separately and anesthesia separately, maintain meticulous, accurate and complete records, and properly supervise all junior staff, follow established protocols and standards of care, and do not leave the patient unattended under anesthesia. So if you follow all these uh, areas where mistakes can happen, these are all the common areas they have found: not taking a proper pre-anesthetic evaluation, or not taking a proper consent, not maintaining proper records, not supervising the junior staff, just leaving the patient and the junior who has just joined anesthesia and going away. These are all the areas they have found that mistakes have happened and vicarious liability has applied. So this is the local tenants physician independent contractor. So I think this is again a repetition. The final messages are: first and foremost, make every hospital should have a professional liability coverage. That is why we take a professional insurance. So it is very important that all the practicing doctors, whatever be the specialty, except areas like dermatology or other minor specialties where they don't deal with any acute life-threatening emergencies, all the others, especially surgeons, anesthetists, and obstetricians, they all should take the proper professional liability coverage from the insurance. This is important because healthcare liability claims can do rise from actions of non-physicians or non-professional persons also, like your theater boy or a technician making a mistake, then you will have to pay a huge cost on that. So for that, it is better that you have a good liability coverage. Second is employees should be always supervised when they do the work, and problem employees should be removed from service. So patients who have a bad record of negligent activity should not be retained in the hospital and they should be removed. And the third is whenever you allow a locum tenens, that is visiting physicians are there, patients should be directly informed that the doctor present is a substitute and not an employee or a physician on practice of the hospital. So if you do these three things, and nothing can absolutely prevent a lawsuit. So taking these simple steps that can at least reduce the anxiety associated with claims involving employees and independent contractors put you in good position to defend those claims. So that is a way to safeguard yourself also to be included in this answer. Now coming to the second part of the informed consent, is an ethical and legal concept. Informed consent is grounded on ethical and legal consent because patients have the right to decide what is to be being done to their bodies, which is called the personal autonomy. So in the theory answers, these are all terminologies which the examiners expect you to mention because these are all given in the textbooks. So you have no other go except to memorize them and reproduce them in your answers. So patients have their personal autonomy and agree to the potential consequences of healthcare intervention, which is called the self-determination and self-decision. So patient should decide whether he wants to undergo this or not. And the first is common law battery, that is performance of a procedure with, that is unauthorized touching without a valid consent is the first mistake that can happen. And the second is negligent failure to warn or tell the patient in advance what are the consequences of the treatment that he is going to face. And failure to obtain informed consent can result in the following thing. One is the compromise patient's autonomy, that is, patient should be able to decide. Second, may increase patient safety risk due to incomplete patient-clinician communication. It may constitute negligence. So if you have not informed and got the proper consent, it may be an act of negligence. It may be battery, that is insulting a patient or trying to unauthorized action on the patient. And breach of control or legal claims may lead to professional indiscipline. So these are all the consequences that may happen because of failure to obtain consent. And if you get a robust patient-centered informed consent, it's a model of shared decision making. What are the advantages of that? It enhances patient safety, improves patient satisfaction because you are already explaining well before what is happening, and meets ethical and legal duty to the patient, and increases staff morale, reduces legal risk to the healthcare provider and organization, and ensures compliance with regulation and accredited requirements. So legal requirements are also met in by taking a proper. So there are consequences which are mentioned. There are advantages or the benefits that are obtained by a good consent. And informed consent is more than the signed form. The anesthesia professional and the patient develop the anesthesia plan through discussion of alternatives and risks and benefits of the plan. So for example, if you want to do a TKR and you say the patient that spinal anesthesia is best, but patient has heard from some relative that they had spinal anesthesia, following which they are having now chronic backache, and he has formed an idea that spinal anesthesia will produce chronic backache. Then he says, this is what happened to my relative, I don't want to have that. Then you can explain the benefits of that particular anesthesia technique. And if the patient is able to understand and he agrees for that, you can go ahead and do that. But threatening him or over exaggerating the benefits and trying to undermine the complications, it will always amount to forcing your technique or forcing your choice on the patient. That is called coercion. So the elements of anesthesia that you do will be the following ones. The first one is the competence and decision making capacity of the patient. This has to be the first criteria for taking the informed consent. And the patient has the legal authority to consent and to decide. So that giving the consent is called the competence, and to decide whether it is to receive the treatment is the capacity. The second is disclosure of information. This is to be done by the doctors. The patient is adequately informed of relevant information, and the nature and purpose of this proposed anesthesia technique should be informed. The risk, benefit, side effects of the anesthesia technique should also be informed, and the alternatives, like you can also have GA for a TKR. That is also one of the techniques which is allowed, and what is the risk and benefit, side effects of that also has to be explained. And the risk of not receiving the anesthesia care in case of a very emergent situation or a unavoidable surgery. If the patient says, what will happen if I don't have the surgery and anesthesia, that also has to be told. Then the understanding of disclosed information. So once you have told the patient all the information, you should make sure that patient has understood that. So the patient demonstrate understanding of the information disclosed, and then he have to give the voluntary consent. Patient should voluntarily consent to the planned anesthesia care in the absence of coercion and duress. This is what I told you about Don't try to impose your preference to the patient. So he should fully understand and give a wholehearted voluntary consent. And the fifth point is documentation. The healthcare record contain appropriate documentation evidence for a patient's informed consent for anesthesia. So these are all the 5 elements of informed anesthesia consent: competence, disclosure of information, patient understanding of the information, then he gives the voluntary consent, and the whole thing has to be documented. Now, a few description about the competence and decision making, patient's legal authority to make the health care, and if he is not in a state like a minor, then parents or legal guardians are the people who are to give the consent. And some of the countries or states have a law where even minors can give the consent. And especially in the USA, there are conditions where a minor who was already married or engaged in active military service, living independently from their parents, pregnant, and parents of children already high school graduates, and seeking specific type of healthcare treatment. These are all not in India, but abroad. There are conditions where even minors can give the legal authority, and sometimes they may also have to be in discussion when you take the informed consent along with the parents. Minors also should be involved, and they can give their own ideas and voluntary agreement or accepting the for procedure. And this is the competence of the patient. Decision making capacity is the legal authority to provide consent. Patient's ability to make a meaningful decision at a specific time about whether or not to undergo anesthesia is what is called the patient's decision making capacity. And an anesthesia professional evaluates the patient, determines capacity to make the healthcare decision by the patient, and which situation this capacity will happen is when the patient has a normal mental ability and rationale to understanding. For example, if a patient is elderly, and as I said earlier, if he has some cognitive dysfunction, not able to hear properly, or have a slight dementia, then mini mental state examination or seeking psychiatric, ethical, legal consent is important. And once a determination has been made, document determination of the patient's decision-making capacity, that is objective facts supporting the decisions, where we can visibly see a patient is absent-minded, forgetful, and having cognitive deficient. All these things have to be documented before deciding whether that patient can give the consent or not. And patients are incapacitated to give a consent or make a decision, then you have to have somebody who has to make a decision on their regard. So the patient himself can delegate his or own kith or kin to make an informed consent, or somebody in the family should take the responsibility of giving the consent for a person who is not mentally stable. So the decision continues throughout the patient anesthesia care unless expressly withdrawn by the patient himself, either orally or in written. So if somebody else surrogates for giving the consent on behalf of a mentally challenged person or a person with cognitive dysfunction, that consent will be valid unless it is withdrawn by the same patient or by the next kid who is responsible for that. And regarding the disclosure of information, provide patient with information that is relevant and helpful, and unnecessarily frightening the patient with all sorts of complication and sequelae are not definitely acceptable, because it will amount to making the patient get frightened and then trying to get the information. So informed consent begins with the explanation of patient's decision-making role itself, and continue that. And patient is encouraged to ask questions related to anesthesia care, and you should be able to answer them. And the goals for the care are possible recovery concern, post-anesthesia period also should be discussed during that disclosure of information. And this should be reasonably foreseeable and does not have include every possible risk. That's what I said. You don't have to say that you may even die on the table. That sort of disclosure is not necessary. So reasonable risks like hypotension, nausea, vomiting, all these things have to be discussed. And what are the special considerations in getting informed consent is disclosure of unplanned conversion to general anesthesia. For example, you say a patient, you explain that spinal is good for PKR to a patient. And unfortunately, the procedure gets prolonged or the drug effect wears off the patient at a premature stage when the surgery is not complete. And intraoperatively, you need to convert it to continue with the surgery to general anesthesia. So that also should be informed well in advance to the patient. So the anesthesia professional discusses the patient the need for conversion to general anesthesia in case of inadequate sedation or if regional anesthesia gets worn out or the emergence happens. So this allows the patient the opportunity to discuss any concern he or she may have related to general anesthesia. So patient will be all the time thinking that they are going to be awake and come out of the theater awake because you have explained that the spinal anesthesia will make only your lower part of the body numb and you will be awake, and I will give you some drugs to make you slightly sleepy, but you will be able to hear the noise. You may hear people talking, all these things happen. And suddenly you start general anesthesia and he becomes unconscious. Post-operatively, he may say, "Oh, doctor, you said I will be awake. Now I was not conscious at all." So that may lead to problems. So that is the reason why you have to inform that whenever there is a regional technique, if there is a O-now, but most of the time we don't tell that because many times we are able to finish that within the duration of the regional technique, and in very rare cases that wears out, we inform them on the table and then go ahead with that. But that is not the correct way. It has to be explained to each and every patient. And the patient understanding of the disclose, that is, these are all further explanation of the previous 5 points that I said as the elements of informed anesthesia. So the patient must demonstrate an understanding of the plan of anesthesia care and decide whether to receive the anesthesia care or not. And variables such as language, cultural, religious beliefs, health literacy, and health impairment, they all form a very important part in getting the consent, because patient has to understand what you say. So it should be explained in the language that patient understands and is in conversant or fluent with. And then coming to the voluntary consent part of it, voluntariness indicates the patient consent is free and voluntary without any external influence like coercion, persuasion, or manipulation. And the exaggeration of the harm not consenting to the recommended care and the benefits of accepting the recommended care is also considered as coercion. So you should not give too much of a very high hope about regional technique and discourage GA. And if it so happens that the regional wears out and you have to give GA, patient will be very frightened because you have told many negative things about GA. So don't exaggerate the harm or don't exaggerate the benefits also. So be modest in your explanation. And the patient has the right to withhold consent or revoke the consent or provide consent after initially withholding the consent. All the powers lie only with the patient in giving the consent. He can accept, he can reject, he can change his mind like a politician and say, I won't agree initially and then later on agree for that. And documentation is the last part of the 5 elements that you have to remember. And following the interactive development of the anesthesia, informed consent decision, everything should be documented. And the informed consent should not be signed until the patient's questions have been answered to his or her satisfaction. That is a very, very important part of that. And witness signature, verify that the witness saw the patient or the legal decision maker sign the document. So you should not get the patient's signature and go to another room and get this witness signature. So both of them should be in the same vicinity, and the witness should see the patient signing the document first. Then only the witness should sign. That is the way it should be. But in many hospitals, they will get the patient's signature and then take the case sheet out and call who is the relative, who is the son, who is the daughter, and get their signature in a separate place. So that should not happen. And the date time should be noted. This is a very important thing. And if a significant change to the agreed anesthesia plan occurs after patient is sedated or anesthetized, then the reasons for the change should be documented in the record. It need not be informed to the patient, but it should be documented in the record. And formal documentation of informed consent provides evidence in the court of law. And the informed consent process has been completed, substantiates billing, and may help protect the anesthesia professional from legal liability or disciplinary action. And patient subsequently challenges the proposed care. That is, if they go to the consumer court also, if you have a proper informed consent provided, that will safeguard you. And timing of anesthesia and informed consent, that is another important thing. For example, you see a patient today and elective surgery is posted after 1 month because patient has some relative to come from abroad, or he has to get ready with the finances, or he has to get the insurance company approval. So how long a consent is valid? That is the important thing about the timing of anesthesia informed consent. So it should be obtained within a specific time period prior to the procedure, and the process and form should be based on patient's current health status. So if you plan a surgery after 1 month and you see the patient today, a lot of change can happen into the patient's health. So the patient's condition changes after the process has been completed, then the risk benefits and the alternatives also have to be changed. So the anesthesia professional and patient should engage in the informed process again if there is a change. For example, an elderly patient posted for hernia 15 days later, you see him today. After 1 week, he develops a chest pain and there are some ECG changes. Then the examination, everything should repeat again and make sure that the patient is fit enough to undergo the surgery. So the time lapse between the anesthetic assessment should be as close to the surgery as possible. So seeing them at a very early period before anesthesia and surgery is the main reason for some of the complications that happen in the process. And if it is emergency, it is considered as implied consent, as you said. So if it is a life-threatening condition, the patient is unconscious or not able to consent, then it is imminent that you have to get everything documented properly, and then it is considered that consent is not required in these situations, and that the emergency should be documented in the patient's record. That is a very important. And secure the consent for legal decision maker later on. That is the kit and kin have to be, or close family members have to to the consent, but there is no legal decision maker. They can approach the close family members. Now, what are the information that you can withhold from the patient? Some patients may limit the scope of information. Some patients may not require or may not accept to get the information that they want because of fear. For example, some patients are needle phobic. If you say, I'm going to give a jab on your back, they may be frightened. So some patients may say, doctor, don't tell me anything, just do the right thing and make sure that I am pain free and I am safe. That is all I want. You need not explain to me what you are going to do. So if that is the wish of the patient, then you can withhold the information. So some patients may limit the scope of information. Their preferred method of receiving may be difficult, or even waive the right to receive the information. So if they refuse to have the information, you have all the legal authority to withhold the information. And they may want certain information to be withheld. This will arise, for example, you make a diagnosis of cancer and the surgery is going to be for cancer breast, and the patient does not want the family members to know that, then you should not be telling everyone, and the information can be withheld from which involve the family members and caregivers. So that is how you can withhold the information also. And anesthesiologists are within their limits of applicable requirements and respect patients' voluntary choice about receiving information and healthcare. So it is the patient who ultimately decides whether he wants to have the detailed information or disclosure of information or not. What are the special situations where consent will be a problem? Critical care and emergency, Jehovah's Witness patient, where you have to get the consent for, the consent getting for avoiding transfusion is a very important thing. Obstetric patients who may require an emergency surgery or chronic pain treatment. There also you have to give all the information properly, because all the patients undergoing chronic pain treatment may not give 100% relief. So unless all the information has been properly given to them, they may sue you in the court of law, saying that I was thinking that I will be totally pain free, but now my pain is still there. Similarly, when you are going to involve a patient in research work or teaching, that requires a special consent, mentioning what is the purpose for that. And fresh consent should be taken for a repeat procedure. So as I said, if you do a laparotomy and then do a re-explorative laparotomy, or even a burst abdomen requiring a secondary suturing, everything you have to take a fresh consent for the individual procedure. And surgical consent is not sufficient to cover anesthesia care. So many hospitals, they get the consent of the surgeons and mention the surgical procedure alone. They don't mention the anesthesia technique. So they say that it may imply that automatically patient will be given some anesthesia to surgery. It does not hold good. So it has to be a separate consent for surgery and separate consent for anesthesia. And blanket consent for anything, everything, even if you get a signature, that is not valid. And consent for blood transfusion also should be done separately, because not only for Jehovah's Witness, even in regular transfusion, patient, if you anticipate there is a need for transfusion in the surgery, because patient is on the borderline anemia in the starting phase, or some hemorrhage is anticipated, and you plan to give intraoperative blood transfusion, then separate consent should be obtained for that also. Now the guidelines, which is another nutshell to make your answers, write your answers faster in the exam. This first thing is the consent should be for a specific procedure, give voluntarily by competent patient, and the complications which are common, less common, or less likely also to be explained to the patient. Risk related to patient comorbidities should also be explained, and adequate time should be given to read and understand the consent form. That should be from the patient side. Honest answer should be given to patient questions, and patient should be given the choice to choose from various anesthetic options given, and whole discussion and patient decision for intervention should be precisely documented in patient's vernacular language. This is a very important point. And patient should sign the form carefully after going through it carefully. And this is a model form which you would have seen in many hospitals. Here the patient's name is given, age and gender, medical record number, address. Proposed surgical procedure is the first thing that is given. Then it says patient gives a free and voluntary consent in a fully alert state of mind to the administration of general or regional anesthesia with or without sedation, or local anesthesia with or without sedation only, for the performance of particular surgical procedure, which is given here, again repeated, on me or my patient, I agree to be supplemented of administration of other mode of anesthesia during course of procedure or surgery if necessary. And I have been explained in a language that I understand the procedure involved in administration of various types of anesthesia, together with expected benefits and associated risks, including the risks that are specific to me. I have had an opportunity to discuss and clarify any concern and ask questions regarding the anesthesia procedure or alternative methods, and the same have been satisfactorily answered. I have been given patient information sheets and information material like CD regarding the proposed anesthetic technique, which I have fully understood. The patient is saying that. If all these wordings are there in the anesthesia consent form, then you are legally very, very safe. And I have explained the risk to the undergoing the blood transfusion, and I'm not willing to undergo the transfusion. This is if it is a Jehovah's Witness, they will say I'm not willing. So that also is documented. And I have been explained the additional high risk of anesthesia due to emergency nature. If it is an emergency procedure, inadequate fasting period, difficult airway, coexisting or morbid conditions such as whatever diabetes, hypertension, ischemic heart disease, all these things can be mentioned here. And I have been explained the risk of dental trauma and subsequent morbidity that may happen. I have been explained the need for post-operative ventilation intensive care unit following my surgery if applicable. So then the patient signs here. Then the relationship of the patient to the proxy, in case patient is not signing, it is one of the patient authorized person who is signing, then that person's name and signature, place, date and time are mentioned. And the next column is anesthesiologist declaration. I have explained verbally to the patient to the details about the anesthesia technique and procedure, related risks, advantages and disadvantages. I have given the patient opportunity to ask any questions, and I have satisfactorily answered them. So here the anesthesiologist writes the name and signature, place and date and time. Then when both of them are signed, a witness who is seeing both of them sign, then they sign here and they give the address, date and time. So this is how a proper informed consent should be taken. Okay, some of the common mistakes or fallacies that can happen is procedure is considered very trivial. For example, if you want to do an INT for an abscess, you think it is a OP procedure and you just spray a local anesthetic or drive analgesia and try to incise and let out the pus, and you don't take a consent. That results in a pain shock and patient has a arrest. Then you are in trouble. So any procedure, you have to take a consent. Even for an IV transfusion, literally speaking, you have to take a consent and then document it and then only do that. And consent of relative is taken instead of the patient when patient is competent adult. That is also a mistake. Consenting person, minor, intoxicated or of unsound mind, and you take a consent from them, that is a mistake again. Blanket consent is taken, that is also a mistake. It is not a procedure specific. Consent for blood transfusion is not obtained. Fresh consent is not taken for repeat procedure. Procedure related necessary information is not given. Even if the information is given, it is not documented. And consent lacks the signature of the treating doctor. Consent is not witnessed. And alteration or additions are made in the consent form without patient signed authorization. Okay? So these are all the mistakes that can happen, and that is all I have to say about that. So remember those 5 elements of informed consent, and then some little detailed explanation about each and everything, and what are all the mistakes that can happen. So if you formulate your answer in that way, it will be a better presentation, and it will also give you a good idea about how to write this question if it comes in the exam. This question has been repeatedly asked in several papers, so I thought it will take a little time to explain the whole thing. Any doubts on that?